Here are some of the mimicking comorbid conditions of autism spectrum. The first one is social anxiety. It looks very similar. If you think of a Venn diagram and I had autism spectrum in the middle, I could draw circles around that whole centerpiece and write different conditions in each of those other circles. I could put social anxiety and say all of the traits here are similar, but this is what's different about the two of them. They have that little bridge, if you picture that Venn diagram, that section, they have some traits that are pretty similar, but they do have their differences. Does anybody know what the difference is with social anxiety versus autism spectrum? They're going to struggle with communication. They're going to have that anxiety. They're not going to do well socially. They may not have any friends. They may not seem motivated to go to parties or join the dorm activities. What do you think separates it from being autism? When does social anxiety start? Is it something they're born with? It's usually an event or a period of time when they can pinpoint. Parents might even say, they weren't like this in 2nd grade. 5th grade, they were this, they were that. We've had parties here, da-da-da-da-da. Something happened in middle school and it just turned off. That is not autism. That is social anxiety. All of those traits that are similar, they didn't originate at birth. People on the spectrum have struggled from day one. I had a young man in my office the other day. He got a full ride scholarship somewhere, wonderful school, magna cum laude graduate from high school, never made a B in his life, went away, came home with all Fs, first semester. This isn't academic or intelligence or anything. He literally could not survive. He didn't know what to do. Parents were shocked. What happened? He hasn't struggled with academics before. Let's look at what he's struggled with all his life. Socially, executively, handling himself, taking care of himself, knowing what to do and when to do it. It's debilitating, right? But we have to go back and look at where did this start? Because if he has been fine socially all his life and then went to college, I wouldn't have suspected that, right? Looking at him, there were some soft signs. His language, his tone, his word usage, the level of speech he had, different peculiarities about him, things like that. We're in the process of diagnosing. I won't tell a parent right off the bat just by looking at somebody for 15 minutes, even if I have this hunch or that, because I know that we have to pull apart those similarities and we need to rule out or confirm or look at something else. But I will mention, I suspect there is enough information that it would be worth testing to find out. And then I leave it up to the family. I don't want somebody to leave my office and not hear those words from me, even if I never see them again. Even if they disagree with me and say, well, you don't know me from blah, blah, blah. I feel it's my responsibility at least to give you some information. Them as a parent, they have the right to take that information and do what they want with it. They said to me, nobody has ever said that. But I've thought that all along. No doctor, no teacher. He's been in counseling before. Nobody's ever mentioned they suspected maybe he could be on the spectrum. We'll see. Very interesting. We talked about social pragmatic communication. I put no RR, that's no ritualistic repetitive behaviors. ADHD, depending on the severity level, I think we've all seen children, of course, with ADHD, maybe adults. I'm talking about the more severe bouncing off the wall, literally cannot sit still to look at you, form a friendship, have a conversation. It's just so much. Sometimes can be confused with autism spectrum. There's similarities. Maybe they struggle socially. Maybe they don't have boundaries. Maybe they don't know how to interact. Maybe they don't use their language very well. They're not, in the right place. There are some similarities. So many studies are being done right now with the commonalities of their social and transitional difficulties, being able to go from one activity to another, being able to go from high school to college, adult life, those kinds of things. We have to make sure that we are not misdiagnosing people, make sure that we're doing it right. Sensory integration disorder. That's just one of the really tricky ones. I like to get the help of occupational therapists when we're looking at sensory issues because they can do a full evaluation on all of the sensory areas that we can't. But we'll work together, and usually it does take a collaborative team to be able to say, this is what I'm seeing, this is what you're seeing. I had a school psychologist not too long ago that we're in an area, the Stone Oak Spring Branch area out there. It's just, we get to know each other very well when you're kind of in that smaller community. And she knows how I work, I know how she works, and we had this one kiddo that was so difficult to figure out. She had some, what we thought was selective mutism. She had some catatonia, she had some echolalia, she had some learning differences, she had some ADHD, she had some spectrum traits. She had everything you could think of, and we thought, no, we're just losing it. We've been doing this too long. We need to take a break. But we really were really confused about where do we start. It took us months and months and months. I had her go to the school psychologist at the high school and let them evaluate. They're going to do it for free. They wanted us to evaluate. Great, let's do both. Comes down, we're finished with our testing, we're sitting at the table, she's got her paper, I've got mine. She's like, well, what do you think? I said, no, what do you think? And we were afraid because we were like, this was the hardest, for me anyway, child that I've ever done, just because it was hard to even get her to speak. We pulled our cards, they're the same cards. I was like, yes, thorough, took our time, no combat, collaborated, really worked with the family, all of those things. Selectively mute, autism spectrum, ADHD, and it was just like matching, and we didn't share anything. These kiddos, you can't do it by yourself. You need to work together. You need the nurses, you need the physicians, you need the doctors, you need the teachers, you definitely need the parents. Sometimes you need the siblings or the spouses. We've worked with employers. Some of the clients that we have are colonels in the military, surgeons, anesthesiologists. I mean, they're professionals, bright and brilliant, and then some that are nonverbal. You've got to use all the information you can. Videos with them, interacting with their cousins if they don't have friends. Anything that you can see how they're, doing their work. For us, we use some techniques like floor time, things like that, just that real warm engagement where we can see if they know how to reciprocate and put some joint attention into their interactions with people. So it's very interesting. Intellectual disabilities, if they're kind of in the 75 range and lower, they can mimic as well. Can an individual on the spectrum have an intellectual disability? Yes. Some of them are lower functioning, some of them are moderate, some of them are extremely high functioning. We've tested individuals that have IQs of 150 and higher. So difficult for them to be able to interact because of where they function. They don't find it. We've had like 4-year-olds test like a 12-year-old. They don't socialize very well because they're so brilliantly intelligent. They don't have autism. Some of them do. But this particular kiddo is just so bright that nobody knew how to interact with him. He was talking about axles. The other kids were talking about Legos. So, it's difficult. Do we just pin people when they're brilliant that way? We can't do that. We have to understand what autism is, right, to be able to do that. So these are some mimicking type. The very bottom one is also probably the most complex. It's the psychosis. If you Google research, and the latest research studies they're doing right now is they're trying to make sure that we're able to determine where that invisible thread is, and you just kind of see clients that tippy-toe over both sides where they're on the spectrum, but they might have some hallucinatory type of experiences. What is that? Is it episodic? Is it psychosis, something they're dealing with every day? If they didn't have medication, they would be hallucinating on a daily basis. Does it only come in times of stress? All those kinds of things. They're saying now that it's very, very close, and the only thing that separates them for some individuals is an invisible little thread. So those are very tricky. Schizophrenia is not on my list. That I find to be very difficult. There's a spectrum of schizophrenia, and so what spectrum are they on? Those are the ones I call the doctor immediately. On the way over here, I was talking to one of the psychiatrists, sharing a mutual client that we have to be able to say, this is what I think and this is what I see, what do you see, and trying to get the conversation before I have to park. those, you have to collaborate with physicians because they're going to be a good information piece. You're also going to be a good information piece for them. They're seeing their client maybe once every 3-6 months. If they're lucky, 15, 20 minutes. If they're super blessed, they're going to see somebody that we work with. They will sit with them for 45 minutes or an hour. Those are the doctors you need to be having conversations with because you need to know what your client or what your patient is working with. These are some hopefully helpful traits of what will an individual that's struggling with sensory processing dysregulation disorder is going to struggle with and how it would mimic autism. Remember, they can go together, but they can also be separate. Here's a side-by-side of what that would look like. There's a lot of similarities in the first two. The very bottom is where it differentiates. You won't necessarily have the repetitive behaviors with sensory. Sometimes you will, especially if they're avoiding one of the senses that's disruptive, you'll see a repetitive behavior, but it's not based because they have a repetitive behavior, it's based on the sensory. That makes sense? So if there's a child that doesn't like the cafeteria because it stinks, and every time he tries to come to the cafeteria, he's throwing a fit and he has to do something over and over to get through that cafeteria smell. And a person's looking at him and saying, wow, they have a repetitive behavior, right? They're doing this over and over, or they're twitching or whatever they're doing. Is it really the fact that they have a ritualistic repetitive behavior, or is it the fact that they're avoiding that sensory, right? So just got to be very careful on what you're identifying. Here's our DSM, and it's in yellow. These are the core areas that you have to be able to identify. If you have the 4 top that are yellow in that individual, but you don't have the 4 bottom traits and core areas, can you diagnose autism spectrum even if you have the 4 top ones? Do you have to have all? What is your understanding of the DSM? How does that work? You have to have all yellow. You have to have all of them. Now, they might not be, let's say you have on the B section, you have 1, 3, and 4, but you don't have 2. That's okay. What I'm saying is you can't have only A and nothing on B. B has to be there. Some other diagnoses are going to look just like A. Social anxiety will look just like A. Social pragmatic communication disorder will look just like A. The only thing that has B on this page is autism spectrum. If you've not used a DSM before, you don't have to know this information. If you're licensed, you should and have to use this information. If you're working in a different capacity, all that's important is for you to be able to recognize those soft signs when they come to you with a toothache, an earache, a learning issue, a social issue, behavior issue, all of those kinds of things. Of course, if you find somebody on the spectrum, you have to designate the severity level. Are they able to function on their own? Do they need support? If they do need support, how much support do they need? When you're diagnosing somebody, you need to be able to scale where they are on that. And does it accompany other types of impairments? So here's social pragmatic. There's the A section. A1 through 4 is almost identical to A1 through 4 on the autism. The different part is on B. This is what their B looks like. Very similar. They're not understanding the humor, the metaphors. I had a young lady who, whenever I would use my hand and I would kind of talk to her and do this, she would look at my hand like if I was pointing to something. But I was just using my hands because I use my hands a lot. And so she takes everything like, okay, like what's she gonna do? That's a literal sense of my communication to her. When I first met her, of course, I'm thinking, oh, okay, you know. We actually tested her, no repetitive stuff. She was just not understanding how to communicate, and she was picking up everything and not sure what to do with it. She's the sweetest girl, but struggling with that social language. Here's social pragmatic communication side by side. Both are early onset, so you might see these types of behaviors when they're 3, 4, and 5. That's just an example. Both struggle social and communication deficits. But that's what we've talked about, because I'm hoping to drill that in you. When there's no repetitive, no ritualistic, you're looking at social pragmatic communication. You're not looking at autism. How do you find out if there's no repetitive or ritualistic? Usually through definite testing. You're not able to see everything in 1 hour. You don't know what their evening routines are like, those kinds of things. So what assessments, what kinds of assessments do we use? Who in here has ever tested somebody for autism? Anybody? Can I ask what assessments you're using? There's quite a bit of variance, I would say, with testing for autism. It depends if you're in a doctor's office, a pediatrician's office, a school setting, you know, our clinic. It varies. And it also varies from state to state. One of the things that I was so, I guess I was a proud Texas girl. We went up to Boston, Massachusetts with a team of physicians. We were invited to come with them. And so we're sitting there in part of the Harvard University, and they're doing this big symposium on testing and things to deal with ADHD and autism. And some of the tools that they were using, we were using. And the people that were on that symposium panel were from Cornell and different, you know, really heavy, high, you know, Ivy League kind of places, and here we are in San Antonio. And so it was very nice to feel like we had some common ground, because I think it's important. I think when we're using those measurements that we're accurately reporting the same thing. It's difficult because it just really depends on where your training comes from and where your setting is and what you're allowed to use and what, for me, you know, I go get what I want. When you're in a school setting, when I was in the school setting, we only used what they gave us and what we had. And there wasn't always a lot of money for training on different things, so it was difficult.